please welcome Matthias and Jens and Daniel.
So we have this paper published in JSEP September 2021, and our approach was like, you all maybe remember this picture. It was March 2020 and Corona arrived to Sweden finally. And for us as frontline workers, it was quite challenging. I literally remember coming to work every day and there was new regulations, new recommendations. So it was quite hard to keep up with what is right or wrong. And we assessed a lot of patients with breathing difficulties in tents like this on the picture by actually only visual appearance, saturation measurement, and maybe a respiratory rate. Quite unusual as we would do. Most of these patients we sent home and we didn't really know how they will do. And at the same time, we had these reports in media and also a lot on social media about increase in venous thromboembolism in this patient group of COVID-19 positive patients all over the world. And this was often subjective impression. So of frontline workers, it was quite hard to tell, hard to measure, is this true or is this just a feeling that it's more? And scientifically, there was not that much data by then. And the first study who came out in the beginning of April was directly from Wuhan in China, who showed for 81 ICU patients that they had a prevalence of VTE at 25%. And just not even 1 week later, there was another study coming out, this time from the Netherlands, where they showed for 184 ICU patients a prevalence of 31% for VTE. And 3 weeks later, Helms et al. From France showed a slightly lower prevalence at 17%. And that's quite hard to know if this is a lot or little if you have nothing to compare. So if we see an ICU population, a general ICU population, we can use the PROTECT trial from 2011. These were over 3,700 patients, and in this population, the VTE rate was at about 7%. So our next question was then, are there other studies who look at VTE and maybe infectious diseases prior to the pandemic? And we found two studies. One was from Kaplan from the year 2015. This was an USA-based study with 105 severe sepsis patients on ICU, where they found a prevalence of 37% for VTE. And another study of Obi et al., also from the US in 2019, where they had a subset of ARDS patients, so severe course of disease for influenza patients, where they found a prevalence for VTE at around 44%. So it feels that we have some kind of clue how it looks for the ICU population, but we still don't know how it looks for the ward, and not for the most important group at the emergency department, for us, the outpatients, which is the biggest group we take care of. So that was where we started our study and designed this retrospective observational study by looking at the cohort of all the adults in Region Östergötland who for some reason did a diagnostic test for VTE. And our time window was March 1st until the last of May. And with that, we covered the biggest part of the first wave of COVID-19 in Sweden. The outcome measure was a pulmonary embolism, or a DVT, and the exposure, of course, was a positive PCR test for COVID-19. To exclude other causes for VTE, we chose the following confounders, which are also known risk factors for VTE, and also included in clinical decision rules like Wells score. And we also checked for the level of care to differentiate ward, ICU, and outpatient groups. We compared this with the same time frame, the same cohort in the years 2015 to 19 in the whole of Östergötland to get an idea how things changed. So here you can see the data set. We had almost 10,000 diagnostic tests in the beginning, CTPAs and ultrasound who looked for DVT. After exclusion, we had a full cohort of 8,702 patients, and they were divided in the control or comparison group 2015 to 2019 and the 2020 group, which had 1,398 patients. And this group was then divided in COVID positive 88, negative 546, and not tested 764. And these numbers, as most of you know, are related to the poor test capacity which we had in the first wave, where only patients who really were admitted to hospital were tested. If we look on the first result table, you can see on the left the comparison group 2015 to 2019. In the middle, we have the 2020 cohort, and the subgroup of this cohort, the COVID positive patients. We have approximately the same age, but in any other concerns, we found a bit what we expected for the COVID positive group. They were more men than female. They were sicker. They had more ICU care, more ventilator treatment, and also a higher mortality. On this slide, we want to show you the annual variation of the VTE cases in Region Östergötland from 2015 to 19, but also to 2020. And here you can see this is a fairly stable course for the whole VTE and also the subgroups pulmonary embolism and DVT. And here we can say our assumption was that even if we only have small amount of COVID positive cases, as this was a really high community spreading in the first wave, we would we wanted to see some signal in our data for 2020 that VTE would go up, but we cannot see this in this data. If we look just in the 2020 cohort, we have the three groups, and we can see that for all the groups, the VTE prevalence is about 16%, no matter if you were COVID positive, negative, or if you were not tested. And on this slide, I want to take some minutes to explain this slide where you can see the prevalence of VTE by the treating unit. To the left, you have ICU and ward, and these were patients who were at least 24 hours on the ICU or on the ward. And to the right, you have columns for ICU admission and ward admissions, and these were patients who coming to the emergency department and were admitted. And the first 24 hours after this they come into the left group. Why did we do that? For us, it was important to see somehow the stage of the disease. It is important for us to know if the patient comes at day 6 or 7 with a COVID infection, if they actually already have a VTE by then, or if they develop it later on, if they are on the ICU or in ward and develop a VTE day 3 or 4. That's like different things, and they have different risks. So that's why we separated the patients we meet, sending them home or admit them, and the patients who actually were in the hospital for a longer time. So if we start with this group to the left, we have the ICU patients, and we see that there is a higher prevalence for VTE for the COVID positive patients, almost double the amount of the pre-pandemic level. For the ward, we see that there's less VTE findings in the COVID positive group compared with previous years, but otherwise there's no significant difference between the groups for COVID negative or unknown group. And for the outpatients, it's almost the same pattern, slightly a few percent less, but the picture is the same, with no increase for VTE with COVID positivity. And if we look on the ICU admissions, so a patient comes into the emergency department, we see that the patient needs to be admitted to the ICU, but the ICU registrar wants us to do a pulmonary embolism CT to check for pulmonary embolism before the patient gets admitted. In this group, we cannot see a higher prevalence for VTE in patients who are COVID positive. And for the ward admissions, we see a 10% rate there, but it's also lower than the years before. So this is some of our most important conclusion of our data, that ICU patients seems to drive the higher VTE prevalence in this, but and maybe also in other studies, but not the patients who arrive directly to the emergency department, and the patients we meet and the patients we send home. So these seems to be two different groups. And yeah, this could have been overlooked by other studies who didn't differentiate by that. And also here we would have expected a more clear signal in our data if COVID-19 would be a significant risk factor leading to VTE, then we would have expected more findings in the outpatient or the ward group overall. Of course, our study also has limitations. One is we have a selected cohort in two ways. The first is that a physician ordered a VTE test. Somehow this physician thought of, oh, this might be a VTE. And there we introduced some kind of individual assessment for each doctor in Östergötland, which we cannot control for. So a better approach would have been to maybe include all patients who come to the emergency department for shortness of breath and start from there. So this would have been better, but also harder to do. We also had these very limited testing capacities, and we might have patients who were in the wrong group in our data set. They might have been COVID positive, but were not tested, or they are not even in the data set because we didn't check on them. Concerning the power, we were underpowered concerning this small group of COVID-19 positive patients, which led to confidence intervals which were wider, and for a number of items we checked, so that this was definitely a limitation. And maybe the most obvious in this, as it's a pandemic and we just do things very differently than we have done them before, it's hard to say if this changing from normal practice changed our results and the prevalence to it. So to summarize, in our data set, we can't find an increased risk of VTE with COVID-19 positive patients. We have a high prevalence of VTE in ICU patients with COVID-19, as it was shown in previous studies. And there was no difference in Östergötland in the VTE prevalence between the group of 2020 and the comparison group of 2015 to 19. So this was the end of our presentation, and we're looking forward to answer your questions later. Thank you.